Great. Let's talk about anatomy and physiology. The bread and butter of our work. You gotta understand anatomy, you gotta know where to find things so you know how to treat them and know how to fix them. And then physiology is going to be the study of how the body works. So we gotta understand how the different systems work and how they work together to create homeostasis, which homeostasis is the fancy word of saying a normal body. Everything's at a normal working function. So we want to practice, we want to know where all our organs are, when we push on the abdomen, what are we feeling? What are we looking for in the different quadrants? All our abdomen makes up, there's tons of organs in there, and every different spot you push is feeling for different problems with those different organs. So we want to know how to. We want to be able to visualize what we can visualize. There's not a lot of body parts that we can really visualize, but we do have some landmarks that we can use. You know, our belly button, our nipples, the genital region, kneecaps. Like, you can use certain locations, visualizing locations to help describe what you're seeing. And then topography would be the feeling, knowing what you're feeling and where you're feeling to find said issues. So we're going to jump right into body systems. So tonight we're going to cover three of the major ones. We're going to cover musculoskeletal, we're going to cover the respiratory system, and we're going to cover the cardiovascular system tonight. Once we finish with those, we'll be done for the night. On Thursday night, Garrett will be picking up where we left off. Doing the whole chapter tonight, we figured might be a little too much, and it's a lot of information to squeeze into 3 hours. So we're going to divide it up into probably a 2-hour and a 3-hour lecture. So we'll be diving into this stuff. Some of this stuff can go on for a while, especially with respiratory and cardiac. So we're going to start first with the musculoskeletal. So we have three main functions for the skeletal system and the muscles. So it's going to give, the first and foremost is it gives us our shape. It's what gives us our structure, our support, our strength. It gives us our shape. It's also got the job of protecting our vital organs. Think about our vital organs. What are some of our vital organs? Liver, yeah. Lungs. Heart. Brain. Yep. Think about the organs that are encompassed by bone. So we have heart and lungs. We're protected by our rib cage, right? We got our brain protected by our cranium. Liver sort of is protected by the rib cage, but a lot of it does hang down below it. So it's somewhat protected. Our spleen is protected. It's over here behind the lower ribs here. So think about it. It's protecting a lot of our vital internal organs. And then our bones and muscles, they provide us movement. They allow us to move around. We have our joints and our knees and our arms. Allows us to move, have the mobility to move around. If we didn't have any joints, we'd be walking around like a penguin. It'd be kind of weird. So it provides us all this movement, mobility. And it doesn't mention it on the slide here, but there's actually kind of a fourth function to the bones, especially. It's our marrow, our bone marrow. Helps produce our blood cells. We get a lot of our red blood cells are produced in the bone marrow. Some of our white blood cells are produced in the bone marrow. And that's why leukemia is such a disastrous and horrible disease. It can destroy our bone marrow and destroy our ability to make new cells. The bone marrow also, it stores certain types of nutrients for our bodies. So it has that added function. So there's a fourth function to the musculoskeletal, and that's just the bone marrow in general and the creation of cells. So our skeleton, we've all seen science classes and stuff that have the skeleton body. We have our skull and spine that are kind of together and attached. Ribs, sternum, shoulders, upper extremities, pelvis, and the lower extremities that consist of our skeleton. That obviously we have many more bones than that. Those are the kind of the regions that are divided up. I'm just going to skip ahead to the picture just because it's easier. So our cranium, our skull. Our skull's made up of our face, our facial bones, which are made up of our lacrimal bone, our orbits, our nasal bones, the zygomatic, which is our upper, like the cheek. You can actually feel it if you push in on your cheek right here. That's your zygomatic bone.
You can feel the arch go all the way back.
Yep, you can. And then your mandible is your lower jaw, and then your maxilla is that upper jaw, upper lip area. Be familiar with feeling these points too. So when you go to someone with a facial injury, you'll know what you're feeling. You'll know what a normal jaw feels like versus what a dislocated or a broken jaw might feel like.
That maxilla?
Yep, maxilla is that upper jaw. Yep. So your lacrimal and nasal bones are here. Your orbit's obviously around your eye. So knowing what the, and feel free to like check yourself with these things, like feel your own bones, feel your own things, become familiar with what normal feels like. So that way when you feel abnormal, you'll know what abnormal is. So our skull. So let's talk about the cranium, what encompasses our brain. It's made up of we have 5 different bones that make up our cranium. And each section has a, what they call a suture. It's kind of like a crack in the skull there. So that's like when you're a kid, when you're a newborn baby, this stuff hasn't fused together yet. So they're soft, the heads are softer, the bones haven't fused, they haven't hardened fully yet as a child, as an infant. They obviously will over time. But so our cranium is broken up into 5 different. We have our occipital bone, which is back here. This is our occipital region. Our temporal bone is off to the side here, kind of above the ear. Then we have the sphenoid bone, which is like where you feel your temple here. You have your frontal bone, which makes up your forehead. And then your parietal bone, which makes up the vast majority of this top section and to the back here. So obviously, one of the issues about the head, so with the rib cage and our abdomen, what's kind of some of the benefit to our organs there when we move around?
You stay in place?
They do stay in place, but there's a little bit more room for movement in there. Like they're not hard encased into these immovable like bones. Our ribs are flexible, like the spine is flexible. Everything's can move here. Think about the cranium though. There's no place on here for the brain to move. So the brain can get very easily damaged just with a simple head bang. Bang your head against the wall, bang your head against anything. That can cause serious damage to the brain because there's not a lot of room in there. There's a very thin layer of fluid that separates the cranium with the brain. And when we get into like nervous system and like neurological emergencies, we'll talk about like the different types of bleeds and different types of issues you can have with those thin layers. But they exist and they can become a problem, especially in the elderly when they hit their head easily. If they're on like blood thinners, bleeds can be a very big deal with the cranium.
Is your lacrimal bone, you're like teared up?
Yes, basically, kind of on that side area there. Yeah. So a spinal column. We have 33 vertebrae, give or take a couple. Everybody can actually have a few more or a few less, depending on how your lower spine fuses together as you grow up. But for the most part, 33 vertebrae are all encased, all encase the spinal cord. So our spinal cord runs from the brain to it's usually about here, usually about halfway to 3/4 of the way down the back. So your spinal cord doesn't actually extend all the way down your spine. Obviously, it's essential for movement, sensation, and it also helps give us our upright stature. Our thorax is made up of 12 ribs and our sternum, and its job is to protect our heart, lungs, and our major vessels here. So, spinal column. Very important to know this. How many are in each areas and how to palpate the spinal processes. So when you feel your spine, you're feeling the spinal processes is what we call them. So the bony things that stick out that's what you're feeling. So when we show you guys how to do spinal assessments, when you're touching someone's, running your fingers down someone's spine, you're feeling the spinal processes. What you're feeling is just for breaks or deformities that are in there. So our first section is called our cervical spine. Make up the first seven vertebrae are our cervical spine. Abbreviated C1 through C7. How you typically would write this on paper would be C1, C3, C5. So cervical spine injuries can be pretty serious. This is where a lot of our autonomous involuntary signals come from. So our breathing, our heart rates, our heartbeats, and a lot of other like involuntary functions of our body. The nerves come off the spinal cord in these sections. So it's a very, very serious point when you have injuries to your cervical spine. That's why we're very serious about protecting it when we find injuries to that or suspect someone has had an injury that could injure that particular region. Then we drop down after our cervical, we have our thoracic. This is the longest, the widest range of our spine. It is made up of 12 different vertebrae. Again, abbreviated T1 through T12. And these are, again, continues to protect the spinal cord. And then this is where you'll see a lot of the nerves come off for our arms. And as you kind of get lower, the nerve ending, the nerves for the legs come down. And then obviously all the sensory stuff that comes off from that for like our nerves, for feeling, all that comes down. Then we have our lower section, our lumbar. This is our lower back. Thoracic is like chest, abdomen area. Lumbar is going to be this low back area. It's down in here, kind of right around that curve in your spine. That's going to be your lumbar area. There's 5 vertebrae in there. Typically, this is where your spinal cord will end. Will be usually somewhere in the lumbar spine. After the lumbar, you have your sacrum, which, again, the sacrum and coccyx is where you see the difference between whether you have 33 vertebrae versus maybe 32. It all depends on how your bones fuse. So you have your sacrum, then you have your coccyx, which is just your tailbone. That's basically what the coccyx is. It's just the fancy name for it. Your sacral typically will have 5 vertebrae, and the coccyx will typically have 4. Any questions on skeleton so far?
Do you ever refer to the top 2, C1, C2 as atlas and axis? Why is that?
I've never personally done that. Usually just C1 or C2.
Right.
I think the whole point of it, like C1 is the top one. It's what holds the skull up. So the idea of atlas holding the world up.
Yeah.
And I don't know where they get axis. I'm assuming that's probably the main pivot point of the spine. So it's where we have where our head's able to turn on an axis. So I'm assuming that's where they get their names. Reading the chapter or reading the book, they didn't really explain the names, but I'm making an educated guess on those.
Yeah,
so
I've never seen
atlas just makes sense with the whole idea of him holding the world up, holding the brain up. So yeah, just an educated guess on that one.
Don't worry, it won't be on the test.
No, yeah, that will not be on the test. If it is, I'd be very surprised.
That's what it looks like, though. We have them in school, and they had the little atlas and axis.
Yep.
And the atlas was like flat, and the axis had like a sticking up, and they'd sit on each other.
Yep. Yep. And that's the way all these are interconnected like that. So. Any other questions? All right. So some more of the skeletal issue. Let's get talking about our hips. So our hips are made up of 4 different areas. We have our ilium, ischium, pubis, and hip joints. This picture actually shows a little bit more than that. Shows our iliac crest in here. Shows the coccyx down in here. The pubic symphysis, femoral head. So this is where our femur attaches to our hip and to our pelvis. The sacrum you can see. And then the iliac crest is the actual curvature on the back side here of the pelvis, and the iliac fossa is that flat, kind of concave center part of the pelvis. And that's what we're feeling. When you feel here, you're feeling your pelvis. We're trying to see if that's intact, when that can break. There's a lot of vasculature and veins and arteries that come down through your pelvis. That's what this kind of big hole is in here. So a lot of that comes down through there. So when your hip breaks, if you fall down and break your hip or get into an accident and break your hip, there's a very good chance that a piece of bone could splinter, or you could do some serious vascular damage in there. Not to mention, an internal bleed on a hip your hip can hold up to like a liter of blood that you won't know about. It won't have any external looks. It won't be bruised down there or anything like that. It literally can hold, I think it's a liter of blood. So keep that in mind. If you can't find a bleeding source and you got a patient with low blood pressure that you suspect has a pelvic injury, that could be where all that blood is. Lower extremities, we get down into our femur, which is obviously the largest bone in our body. Our patella, which is our kneecap. Tibia and fibula, they provide our lower leg. The tibia is the main bone down the leg. The fibula kind of runs parallel to it, adding extra support. And then our ankle is made up of 3 different bones. Going back up to our upper extremities, we have our clavicle. Anyone here ever broke their clavicle? It's pretty painful. So it runs, huh?
My brother did.
Yeah, it's a pretty painful thing. Horseback riding is a pretty common cause of it, being thrown from a horse. So your clavicle runs across here. It's that frontal bone up here that runs across your shoulder, where your scapula comes up, your shoulder blade will come up to the point, and it meets at the acromion process, which is this bony point on top of your shoulder. That's the acromion process. And they all come together to form the acromioclavicular joint. It's your shoulder joint. It's where your shoulder comes in. It's where your humerus meets the shoulder and gives you that rotational movement. So, humerus bone comes down from the upper arm, comes into our radius and ulna. So much like the tibia and our lower leg, we have 2 bones in there, the tibia and fibula. Our lower arm has 2 bones also, the radius and the ulna. The radius being the main bone, the ulna providing kind of some extra support and extra strength in there. They come together to form our wrists and our hands. So our wrists are carpal tunnel syndrome, and our hands are metacarpals, and then the phalanges are our finger bones. Any questions on your bones? Pardon me. Really get to know your bone names when it comes time for testing. When you do your joint immobilization and your splinting exam, you will draw a card that will have the medical term for the bone on it, and you will have to splint it or do a sling and swath method. You will have to know what it is. They do not tell you that it's the shoulder or the upper arm. It will say humerus. It will say tib fib. It will give you the medical name. So become familiar with the bone names. Kind of a really bad picture of the skeletal system just as a whole. Can anyone actually see that? It's kind of hard to see, but it basically is just an upright skeleton kind of going with a full list of everything we've gone over. Your book probably has a better picture of it where you can actually read it.
123.
So, our joints. Joints are bones connected to other bones. We have 2 types. We have our hinge and we have our ball joints. Can anyone take a guess at what would an example of a ball and socket be?
Shoulder, hip,
Shoulder, hip. Yep, those are our ball and sockets. How about hinges?
wrist,
Elbows.
knees.
Knees and elbows. Wrists not so much because wrists have a rotational. So hinge, think of it like a hinge. A hinge can only go so far before it stops. Where the wrists can go around in circles. So the wrists don't believe they're considered ball and sockets because they're not really a ball and socket. It's more of multiple bones being met together that allow the rotation. But yeah, hip and shoulder are common ball joints. Knees and elbows, hips, shoulders, knees and toes. Should just play that song for this section. I'll get up and dance. All right. Any questions on that? So joints will be interesting. The first time you feel a dislocated shoulder and you feel that gap, and you're able to feel that gap in a joint is pretty interesting, especially when you start feeling both sides. So what normal feels like, and then when you feel your first one, you'll go, "Ooh, that's not supposed to be like that."
Anybody want to feel one? Mine does it all the time.
You dislocate your shoulder on command.
Yeah, I was a gymnast, so it just kind of. I was actually told they should put a plate in there or like a little thing to stop it from doing that, but I just haven't had the surgery yet. So.
Interesting. All right. Well, we'll use you for an example when we need to do when we need to learn how to do the palpating part.
Sure.
All right. Any questions so far? Cool. Let's move on to muscles. We have three main types of muscles in our body. We have skeletal or voluntary muscle. We have involuntary or smooth muscle. And then we have our cardiac muscle. Cardiac muscle is very special. So skeletal muscle is much like you think it is. It's what makes up our most of our body. It's what makes up our biceps and our quads and our hamstrings. This is all skeletal muscle. We have full command of skeletal muscle. If I want to walk, I command my body to walk. Okay? There's nothing that controls my skeletal muscle except for me and my conscious thoughts. Smooth muscle, which is involuntary muscle, this is muscle that we don't necessarily have full voluntary control over. So things like your diaphragm, that would be a involuntary muscle. Do you have some voluntary control over your breathing? Yes, you do. Everyone in here, you could hold your breath. But as soon as you get out of breath, what happens? As soon as you can't hold it anymore, your body automatically releases and you start breathing again. You don't have any control over that. Or if you're able to hold your breath to the point of passing out, your body's going to just start breathing on its own again. You do not control your breathing. Your brain does. Your brain controls your breathing, controls your heartbeat, controls all that stuff without conscious thought. So that's smooth muscle. Where else might you find some smooth muscle? Besides,
Veins.
Veins have some, a little bit, yeah. A little bit on the outside because they're able to constrict and dilate. Eyelids, that's more of a... How do they classify eyelids, actually? Because you don't...
Because you can control those, but you can't control them. Right?
Yeah, I would imagine those are probably smooth muscles. So think of some internal organs, though, that might have some smooth muscle on them.
Oh, intestines.
Intestines, yep. How about right here?
Lungs.
Yeah, your lungs, your intercostal muscles, your lungs, your bronchioles that make up your breathing, make up in our lungs. All that is, there's a whole bunch of smooth muscle in there too that allows them to expand and contract. All right, let's talk about cardiac muscle. Cardiac muscle is super special. It is an involuntary muscle, which you'd be thinking, well, then it's smooth muscle, right? Aha! One key difference between cardiac muscle and smooth muscle. Cardiac muscle is what has a property of what we call automaticity. You're going to want to know that word, automaticity. Automaticity means that it can generate its own electrical current. So the heart muscle is able to generate its own electrical impulse. It's how it pumps. It's how it beats, is its own electrical impulse. The brain doesn't send an electrical impulse, it doesn't do any of that. It does that through the conductive system and cells called pacemaker cells that actually use this is going to go a little deeper than this is going to go a little deeper than EMT class, but the cells use what we call the sodium-potassium pump. So it uses sodium and potassium to cause a chemical reaction to happen that actually causes the muscles in the heart to contract. So that's why sodium potassium is a very important vitamin that we take in. So yeah, so it creates its own electrical field that allows it to pump. That's the number one special part of cardiac muscle. No automaticity, and know it well, because it probably will come up on a test or your national registry. Something like could come up on those types of tests.
So when you shock someone, you're jump starting that muscle basically to get it to start pumping again?
Yes. Yep. Basically what we're doing is, in the simplest terms, we're creating an EMP. We're basically creating an EMP. We're basically killing off the current electrical in the hopes that it restarts in a normal pattern. So when the electrical system starts to malfunction and we start to get different arrhythmias, sometimes electricity is needed. And what we do with the electricity is we send enough electricity through the heart to override the heart's intrinsic beat. By doing that, it basically creates an EMP force around the heart that shuts that down and allows the pacemaker, the top pacemaker, which we'll talk about in a few minutes, the SA node, allows it to go, good, finally, you buttholes have stopped screwing around, I can regain control, and starts regaining control. That's the hope when we defibrillate somebody or we cardio over to somebody. That's the hope.
But the same thing as why an electric shock could also be fatal. It's too much of a charge.
Correct. Correct. It could be too much of a charge where you fry the entire heart.
Or you time it wrong.
Yeah, or it's timed wrong. So we'll talk about more conduction system in just a little bit. Promise. So Carter, any questions on the three types of muscle?
Is there an identifiable, something that you can describe as to why smooth muscle and skeletal muscle, other than how they function? Like, if I looked at them under a microscope, would they look different?
So they would look a little different. You're going to see, you can kind of see them on here. So your skeletal muscle typically will be wider, will be longer. If you look under a microscope, they would have longer sections of cells. The cells are longer.
Okay.
Smooth muscle typically, I believe, is tighter. And then cardiac muscle is even tighter than that. There's more of them. You can kind of see it in the picture. Garrett, feel free to step in if I'm off on a little bit of these.
You're good.
Cardiac's tighter, but you would literally need a powered microscope to tell the differences. You would never be able to tell the difference between them just looking at them.
Okay.
The main thing is the functionality of them, what each one does.
Yeah, that is the important. You're not going to get asked about what one of these are going to look like under a microscope. You're going to be asked about how they function within the body.
So the skeletal one is the one that bodybuilders flex when they go to shows and stuff, right?
Yes.
Okay.
Yeah. Anything that you control, and well, I shouldn't say anything that basically any of the visible muscles you would see from the outside are typically skeletal muscle.
There you go. You can see a comparison.
Cardiac muscle is also called, as individual cells are called.
If you're looking if you're looking under a microscope.
Ready?
You guys want to see it?
You can pass it around if you want. Or... All right.
That's just if you're looking under a microscope. Look at it.
So that's kind of it for muscles. Is there any more questions about the muscles? About different types or?
Big thing from that is just know what muscle groups are where. That's what NREMT is going to ask you. They're going to ask you what muscle group is located around your vessels. Skeletal, cardiac, or smooth muscle. That kind of stuff.
Very specialized stuff that we do with ruptured muscles or torn biceps and things like that.
No, it's really going to be kind of splinting, slinging, swathing.
You'll be able to tell usually too.
Oh, you could probably tell. I mean, I guess it depends on how bad, a bicep rips from a bone.
Yeah.
You'd probably be able to see, if it rips from the top, it might be smooshed right down, so there'll be a giant gap here where there's no muscle, but it's all packed down.
Contracted.
Actually, one thing that was not brought up here. So just keep the way bone connects to bone via ligaments. Should definitely mention that.
Yep.
Bone to bone is ligaments. Muscle to bone is your tendons. So your tendons connect your muscle to your bone. Your bone's connected to bone by ligaments. I swear to God, we should just literally sing head and shoulders, knees and toes during this lecture. But yeah, so know those. Know the difference between ligaments and tendons.
That comes up later.
You might see it later. It'll come up. It can come up on times when we talk about just injuries to muscles in the skeletal system.
Will we need to know muscle groups specifically, or just?
I would know the major ones.
You shouldn't have to know muscle groups. No,
Okay.
I don't remember ever knowing. What they want you to concentrate, like Garrett said, is know the functional differences between the three.
Yeah.
When you go on to advanced level, then you might be expected to know certain muscle groups.
Just kind of your major ones I would know, like your pecs, bicep, tricep, rhabdos.
Should you learn them? 100%.
It wouldn't hurt you.
I say go ahead and learn them if you can, but
It's
don't
not
sacrifice
required
other
for the course.
sections to
It would
memorize
be
those.
helpful in a PCR or something like that.
Yes.
Okay.
It'll be helpful as an EMT to know your muscle groups, but it's not going to be required of you to know for testing.
Okay.
So let's put it that way. So yes, feel free to learn them if you want to study. Study that stuff. Feel free to learn.
It's
learn
more if you're
those.
giving like an IM injection, you have to say your site you're giving an IM injection, whether it's lateral deltoid,
Lateral thigh.
lateral thigh, gluteus, whichever. It's more where you would need it.
All right. Any more questions?
Yeah, real quick, sorry. You said
Yeah.
bone to bone is ligaments. What was the other one?
Tendon is muscle to bone. Tendons connect your muscles to your bone. So typically when your bicep collapses, it's a tendon that blows out and your bicep falls down or retracts up.
Thank you.
Pretty painful from what I understand. Never personally done that, but I've seen,
ACL and MCLs, all the ligaments in your knees,
yeah,
Yep.
those are the most common that are torn. Sports injuries.
rotator cuff is a tendon.
Side topic for my buddy when we were in high school. Tore his ACL, his meniscus, and his MCL all in one flow.
That's a bad day.
It was
Those
rough.
are common
Skiing?
football injuries.
No, we did a lot of flips and like free running parkour type stuff in high school, and he was doing a move called the cork, so it's basically a 360 backflip off of 1 foot. And when he landed and his knee kind of went inwards and just tore it all.
Yeah.
It was rough. I had to like carry it to his house.
Yeah.
All right. Let's go on. Let's talk about the respiratory system. Respiratory system is probably one of the two biggest systems you want to get to know intimately. It's a very important system. It's what brings oxygen into our bodies, allows our cells to function, allows our heart to keep pumping. And the other important thing is it gets rid of carbon dioxide. These are the two main functions. Bring oxygen in, get rid of carbon dioxide. These are the reasons we breathe. We breathe, like Garrett said in, was it pharmacology? We breathe to get rid of carbon dioxide, right? That's why we breathe. We don't breathe because we need oxygen. We breathe because we need to get rid of that CO2. It's called our carboxylic drive. So, air is going to enter our body through our mouth or your nose. Some people are more mouth breathers, some people breathe through their nose, or if you've got a cold, you might breathe through your mouth more. The biggest point of air coming in through our nose and our mouth is there's two big reasons, or actually three big reasons. It cleans the air, takes some of the microorganisms out. That's what we have that's why we have hairy noses. That little cilia in there that helps clear up some microorganisms out of the air for us. It also warms the air, brings it up to kind of a body temperature. It's important. We've all breathed cold air in the middle of winter. It doesn't feel good. It sucks when you come from a warm environment out into -5 degrees. It hurts to breathe. Well, the whole point of that is to help bring that air up to a normal temperature. And the last thing it does is it moistens the air. It actually adds a little bit of moisture to the air that we breathe in. Our lungs have moisture in them at all times. It uses what we call a surfactant. It's like basically like a grease. It's a kind of a saliva-based oil-ish kind of that secretes in there. So we want to keep everything wet inside our lungs to a certain extent. And that allows the air to come in, allows everything not to dry out and collapse. So we're going to come in, we're going to breathe through our oropharynx and our nasopharynx. So mouth, nose. Naso, nose, oro, mouth. These two meet up in the back of the throat. The back of the throat is called the pharynx. It's where they meet. From the pharynx, it's going to enter into the trachea. It's going to flip over the epiglottis. So our epiglottis closes over our trachea in times like when we eat, when you swallow. The epiglottis is like a little flapper cap. It flaps over the trachea and keeps food and water and other liquids from going down our trachea. So it's a protective. So when you choke on something or, accidentally try to swallow and breathe at the same time, I'm sure everyone in here has done that, and you get that coughing fit, that's because you have somehow managed to, before the epiglottis can close, you have managed to swallow something down your trachea. That's why we get that coughing fit. The body's trying to get that out of there. Doesn't like stuff, doesn't like foreign objects down there. So as we move towards our lungs, we're going to hit the larynx. Our nice little voice box. Gives us all our wonderful pitches and our talking and our singing, if you're into that stuff. I can't sing. It's where our vocal cords are. And then the lower portion of the larynx is called the cricoid cartilage. And you can actually find it. You find your Adam's apple. It's right about in here. And just above it, you'll feel a little gap in the rings. So it should be right about there. Everyone find it? You're going to just need one finger to find it.
Really struggling to find my Adam's apple at the moment.
Go up. Go up on your neck.
Yeah, kind of extend your
There
neck
you
out,
go.
and then if you talk, you should be able to feel the.
Feel your voice box. You can feel the vibration, right? If you talk, if you hum while you do this, you'll feel your voice box. Your cricoid cartilage is going to be kind of right in that center. So that's an important thing to know where it is. It's not going to be super important to treatment for you guys. For the medics, it does, because this is actually where, if someone has a blocked airway above that, this is where we're actually cutting into their throat and putting a breathing tube in.
I was gonna say, is that where the...
Yes, this is where we do a cricothyrotomy. It's where we literally cut the throat open, stick a breathing tube in to bypass that blockage. So, but it's a good thing to know where it is, because when it comes time for a paramedic to intubate or something and you're there helping them, there's a thing called cricoid pressure. It's also called the Selleck's maneuver is the other name for it. So when you take this, when you take two fingers over the cricoid cartilage and you push, you're going to push down on it. What this does is it's going to push the cords down. So as the medic's looking in, you're going to push this down as they're lifting up. So it actually gives them a better view of the vocal cords past the ET tube. I don't have a picture of it, but
It's called the burp technique. You push backwards, upwards, rightwards, and pressure. You guys work with a medic, that is a technique you're going to use often, because it really helps.
Yeah.
Backwards being...
Backwards, back,
Posteriorly
posteriorly,
back.
yeah.
pushing back, up to the right with pressure.
You're right.
The patient's right.
Patient's right, yeah. So after we pass the larynx, we're going to hit the trachea. So trachea is our main tube from the larynx down into the lungs. We have the trachea. It's the main chute. Once we hit the bronchus, one's bronchus, two are bronchi. So where it splits, it's another name you probably want to become familiar with. It's called the carina. That's going to be this point right here. Right where the two bronchi come off from the trachea, that is called the carina. Will be something you will want to know. It is can be an important landmark.
That
to
was
know.
on my NR EMT exam. You know that term, carina.
It's in the practice pack from Quizlet.
Yep, I believe it does mention it in the chapter too. I just don't think it goes into a huge
So where
detail
your
on it.
trachea branches off into your primary bronchioles, that first branch, that point is called the carina.
Once we hit the bronchi, they continue to, so our bronchi continue to narrow, basically, and split off into smaller and smaller tubes called bronchioles. So you go from your bronchi to your bronchioles, and then you terminate at your alveoli. So our alveoli are little tiny sacs that sit at the end of the bronchioles. So they look like this. They look like little egg sacs. A lot of surface area on them with veins on one side and arteries on the other. Actually, that's the other way around here. Veins over here, other capillaries over here. So the capillary beds encircle each alveoli. This is where gas exchange happens. This is why alveoli are one of the most important parts. This is where the gas exchange is happening. O2 is coming from the alveoli into the bloodstream. CO2 is going to come from the bloodstream into the alveoli and get ready to be expelled. So we want to keep alveoli as open as we possibly can. So this is the point when we're talking about like CHF and COPD patients. This is why we use the drugs and the pressures that we do with like CPAP, with the masks. We want to force these alveoli to stay open, or alveolus. I guess alveolus would be single, alveoli would be a group, in case you want to know. Some other points too about the airway anatomy. So your lungs are covered in what we call the pleura. So it's just a protective sac around our lungs. There's a little space in between your lungs and the pleura called the pleural space. And fluid and blood can often, or even sometimes just air can get into that. This is where like pneumothorax and hemothorax come from. You get a little air, you get a little snip in that pleural lining, air gets in there, and now it collapses the lung because it changes the pressure inside. So let's talk about the process of breathing. Talk about inhalation first. It's an active process. Inhalation takes energy, takes body energy. The energy the body uses, you need to have it in order to breathe. This is why when you start breathing too fast for too long, you start to tire. You start using up your energy. So your diaphragm and your intercostal muscles, so your intercostal muscles are all your muscles in between the ribs, they're going to contract. Your diaphragm is going to move downward, and your ribs are going to move upward and outward. This creates a negative pressure in your lungs and allows air to rush in. That's how breathing works. It's not really the fact that we're sucking air in, it's just the simple fact of we're creating negative pressure inside our chest, and that's what allows us to take a breath.
Understand that concept, because that's something that can confuse a lot of people. Does that make sense, how that works? If you picture a balloon inside of our lungs, we're taking that balloon and we're expanding it, all right? Well, to expand it, you need volume to go inside that balloon. So as that balloon's opening up, air is rushing in. And vice versa, as that balloon collapses, air is pushed out. Does that make sense?
I think I've actually seen that in a science class at some point, like an actual balloon.
Probably.
Type thing.
As you expand volume, you need to equalize pressure.
So in reverse, exhalation is actually a passive process. Doesn't necessarily require energy from the body to exhale. It's just a product of when we breathe in, we build up so much pressure in there that that everything just relaxes. So our diaphragm and intercostals relax. Our diaphragm's going to move back up. Our ribs are going to move downward and inward. This is going to create that positive pressure. Doesn't really require much energy on the body's part to relax its muscles and let things return to normal. That just requires, that makes positive pressure, makes us push the air out. I didn't think about it. Should we bring up dead space here or later?
Talking tidal volume and all that stuff.
Yeah. Should we do that now or should we do that in respiratory emergency?
I would say finish this portion and then we can talk about that
Okay.
a little bit.
So any questions on inhalation or exhalation?
Isn't inhalation also called inspiration?
Yes. Inspiration, expiration also.
Yep.
All right. So let's move on. Ventilation and respiration.
Know these two.
Know these two.
Telling
These
you
are going
now.
to be very
Know
important
these
concepts
two.
to understand. Ventilation is the movement of gases to and from the alveoli. Respiration is the exchange of gases between the cells in the bloodstream. Okay? Very important. Another name you might see respiration entitled as, you might see it called cellular respiration. It's where the cells in the body, not just the lungs, not just the alveoli, but it's all the cells. As that blood's rushing through our bodies when it hits the capillary beds, cellular respiration is taking place. Nutrients, gases, they're all being exchanged by our cells, waste products entering the bloodstream and being carried back to the lungs, or to its necessary point. Liver, kidneys, lungs could be entering several things. So these points are very good. Is there any questions on this? Does anyone not understand the definitions right now? Think of ventilation as the mechanical motion of breathing. Respiration is a chemical. Think of it more as a chemical reaction, chemical interaction between the bodies. So, when we breathe, we get the oxygenated blood, gets carried from our, oh yeah, that comes up in perfusion comes up with the cardiovascular stuff.
Okay.
So oxygenated blood is going to be carried from the lungs to the heart, then pumped to the rest of the body. We're going to talk a little bit more of this too with cardiovascular stuff, just because everything's linked. Our respiratory and cardiovascular systems are so intertwined that they almost should really be their own. They really kind of are one system. You'll often hear them called the cardiopulmonary system. They're just so interconnected and so vital. So then it gets pumped out to the rest of the body. At the cellular level, oxygen gets exchanged with the cells for the waste product, carbon dioxide. This process is called diffusion. So it's so basically diffusion is when a substance moves from a higher concentration to a lower concentration. That's the diffusion in its simplest terms. Is a substance moves from one area that's got a high concentration to an area of low concentration. That's how our body exchanges gases in the alveoli and at the cellular level. There's more CO2 in the cells, less in the bloodstream, so CO2 crosses that cellular wall into the bloodstream, and vice versa with the oxygen. Deoxygenated blood is going to get returned to the heart. Then it's going to go out to the lungs to exchange its CO2 for more O2. All right. So this is the basic principle of the buffer system. They did mention it in the chapter. So the idea of bringing O2 in, taking CO2 out, it's the most basic function of our buffer system. So everybody, as you guys know, our body runs on a pH level. Everyone knows the pH levels, right? Acids and bases from science class. So our body actually is slightly acidic. We sit at a normal, you're probably not going to have to know it, but it's not a bad thing to know. So our body sits at a pH level of 7.35 to 7.45. So we sit at a slightly acidic range.
Alkalytic.
Sorry, alkalytic. Sorry. 7 even would be that breaking point. So we sit at a slightly alkalytic line. CO2 is actually an acid. It's considered an acid gas inside our system. It makes us more acidotic. So we want to get rid of CO2 as much as possible. The more CO2 that gets built up into our system, the more acidotic we can become. This comes into play with our respiratory system, because if our respiratory drive is not functioning properly, we're not breathing, we're breathing labored, we're not exchanging gases properly, CO2 starts to build up in our bodies. You end up in a persistent, tongue-tying myself here. You end up in what we call acidosis, which can go along with infections, diabetes, DKA, diabetic ketoacidosis is a type of acidosis, or you could go the other way. You can go alkalytic, which would be if you destroy too much of your CO2, get rid of too much acid, the bases or your bicarbonate takes over and you become more alkalytic, which is actually worse than going acidotic. In the terms of long things, it's better to go acidotic than alkalotic. I'm kind of jumping into a little bit deeper science with this, but the buffer system is a very important thing. So learning that why we're getting rid of the CO2 and why there's this constant balance is pretty important.
Would that be because it's easier to remove than it is to add type thing? Is that why one's better? Or
What do you mean?
like the,
How our body responds is more effective. So I'll give you a good example. What would be a classic case that somebody would have increased CO2 levels?
Track athletes?
Track athletes, more like, I'm going with like what
Pull somebody from a fire.
disease or anything could cause increased CO2 levels.
Very common cause.
We go to it all the time.
COPD.
COPD, definitely. Break out the Narcan. Opioid overdoses. So when we go to an overdose, what does an opioid do to our respiratory system?
Slows it down.
Slows it down. So your respiratory rate is 4. What's your CO2 doing in your body?
Building up.
Building up.
You're not able to expel.
You can't get rid of the CO2. That's why we give Narcan to get the respiratory drive up. As soon as they come around, the first thing they do is rapidly breathe. Because they've got the CO2 built up in their body, their pH goes from 7.35 to 7.45 to what?
It'll go down.
It'll go down to an acidotic state, right? So their body responds to that by expelling as much CO2 as they can out of their body. So it's a quicker response through the respiratory system.
Yep.
If they're on the other end where they're trying to make bicarbonate takes 2 to 3 days before it really takes effect in our system because it's got to go through our kidneys and our liver to really build up.
Yeah.
That's what's a little
The
better.
lungs are the first line of defense with the buffer system, I guess is the best way to look at it.
That's more in patho when we cover patho, but just to give
Yeah.
you an idea is how CO2 works in our body.
I'll give you one more tidbit on pH. The body can only take a 0.5, plus or minus 0.5 in either direction, and you're dead.
Yep.
0.5 is considered the lethal. So if you go to 7.95,
7.5 to 6.9-ish.
7.9 to 6.
yeah,
0.05
Seven.
difference. So
Yeah.
7.5 to
no,
6.9.
0.5, not 0.05. 0.5, 0.5, either direction.
0.5.
Yes.
Okay, yeah, you're right. Yep.
If it was 0.05, there'd be a lot of dead people
I know.
because a lot of
Getting
people
my decimals
fluctuate like
mixed
that.
You're right.
But yeah, so 0.5 in either direction is considered a lethal shift in pH value. Alright, so
Decimals are okay.
we've talked that. Let's talk a little bit about differences in respiratory with children. So there are some differences. Kids will typically have smaller mouths, smaller noses. One of the biggest things is kids have a proportionately larger tongue to their head size versus an adult. Their tongues are bigger, they get in the way. So what do you think that means for airway issues?
It's gonna block easier, but don't they also have a larger head to their body size?
Correct.
So you always have to look at their shoulders in order to get them into
Yep.
an actual.
Good,
right
correct.
position.
Put them in a neutral position.
Pat the shoulders.
Pad the shoulders. So the tongue becomes, in children, the tongue becomes the number one blockage of an airway. That's why, like, if you have an unresponsive kid that's having trouble breathing, it's important to get some sort of adjunct in there, whether it's an oropharyngeal airway or a nasopharyngeal airway, something to get that air down around the tongue or lift the tongue up. A child's trachea is going to be narrower. It's going to be less developed, less rigid. The tracheal rings, the cartilage hasn't quite hardened perfectly yet. And obviously, as we just said with the tongue, the structures are going to just be much easier to, because of that smaller stature, it's going to be much easier to obstruct those airways. Any questions on differences? Am I missing any differences? Those are usually the pretty main ones.
Yeah. Kids' airway management, the biggest thing is making sure if you're bagging the kid, pad the shoulders. We're going to preach that to you when we get into cardiac arrest and that kind of stuff with kids. Make sure they're in a neutral line so you're not clamping down on their trachea. And kids, the number one factor for kids' cause of death is airway. kids go into cardiac arrest because of some form of airway issue, 99.9% of the time. So you need to manage the airway on a kid primarily before anything else, that and trauma.
All right, let's take 10 minutes before we go into cardiac.
Did you wave to me? Thought I saw you. Was that you? In Boston Post earlier? We're pretty good with this. Everybody comes by. What's that mean?
Not me.
Someone waved to me and it kind of looked just like yours with firelights on it. I was really confused on who it was.
Cody Benson has a blue, what is it for?
What'd you erase that stuff for?
He said they were good with it.
Oh.
Yeah, he wishes.
Really?
Pretty sure he wishes.
Oh, good. If we can do an hour for this, that'll be about 2 hours.
Literally my only issue.
That should be. That's
Doesn't bother me.
It's just the fact, yeah, there's no way you can crank through it in one
But
night.
so do you.
No, no. Especially looking at the way the power plant is set up and be like, oh my god, there's so much stuff to add. They didn't have to worry about that bear down there.
Yeah, we got.
Yeah, we
called
can
for
totally
an
do it.
hour
I
after
think they do that.
the
I know,
fact.
we went-
Fluid.
We went through there.
Yeah. They leave it malleable for your own teaching preferences.
We had
Let me
a,
know how that works. It's
Exactly.
not working for me.
you know,
Yeah, before we end it, I would
I
mention
did a ride
something
along with
about
Joey
like
the
dead
other night, this
space.
guy we were talking to, like,
I don't know.
normal
if
is
we're
normal
gonna
could
post
be.
on
We
that.
were
I don't remember
normal
the
stuff
post on
that
that.
happened, we were talking.
I remember it, I vaguely remember it being at least
Sorry.
that we have like a basic like
Yeah, I heard that
150 mils of
we'd already gone
dead
through
space
it.
here that's always
Well,
in our lungs. And
We heard about
What?
it already
Yeah,
half an hour before we got home.
Yeah, so, well, they were in such a bad spot, somebody else probably came through.
I was the police that had us get dispatched.
I don't know what we're going down.
And the car was already like pulled all the way off the roadway out into like
Yeah.
a field driveway.
Yeah, such a
So-
nasty spot.
We like drove past them, had to turn around. And once we hit like the Berkshire portion of Santa Fe back, we came back and we got canceled. So it's not like it's
Yeah, one, get canceled before we get there. We had one of those this morning, the guy's furnace was leaking, so the alarm went off.
it's been an eventful 24 hours for Bakersfield.
Yeah, I don't know what was going on, they didn't have my board on, but I think they had to do an air lift this morning.
Garrett went to
Somebody shot
Garrett
themselves
went to
in the head.
Bakersfield today.
Oh, you did? You went up for that one?
Good.
Lucky you.
Yeah, he's always complaining how he never gets trauma called and
Oh, you poor thing.
Asking shall receive.
Yeah, they had Avis go.
somebody would sit in
That's
that
the last
chair. Comfy
night.
chair right here.
Actually, we just got a call for ambulance. So we fell off the couch.
So I'm a little behind on videos. I apologize. It was a
Fill
busy
up their
weekend.
couch, hit their
I will
head up,
do my best to try to get them up
They're
in
now
the next couple of days.
semi-responsible. That's like right now?
Like,
That's why I was giggling because you played it for me. Being very respectful.
We've been going to Ian's very little, but frequently. I'm on it tonight when I get up.
are you?
Yeah, Joey's covering me right now. Shelby's been doing the schedule, and I told her like a month ago after I took the shift, and I was like, oh, I got class on now. Just find someone else to cover the whole thing. She never did. So we saw you guys at the station, be half day when we were coming back Saturday.
Well, that's wrong.
Yeah, me and Joey. I was like, I didn't cover it for Monday. I was like, ask Shelby, but she never did anything. He's like, I'll cover you. He's right now with that.
Yeah. It's actually good.
Yeah, don't say that word. It doesn't work on the fire side, but for the that side it does. Well, I said it the other day.
We need to get ourselves like an actual like whiteboard than a stand
Yeah,
over
no,
here.
It's kind of a black cloud some days.
Whenever I'm out of town is when call volume just whoop.
Yeah, this coming weekend's gonna suck for them.
Well, they're losing you, me, Frank, who else is out of town? Assistant chief. Shit, we're probably gonna be down half the department.
We're gonna be down half the responders, half the people that actually go.
That's what I call the department, I'm sorry.
Yeah,
No, we're gonna be down about half the
definitely
department.
know what that's like.
Oh, yeah.
There's a select few that show up like everything and anything.
What, 8 to 10 that
Yeah.
actually show?
Yeah.
We got
Any
like
one day?
5. We got 5 that'll show up like almost anything. Then we got a good 10 that'll show up to the majority.
Depends what it is too.
Exactly.
Yeah, you
We'll
gotta-
see what we get.
You're gonna have to
very
explain
low
that.
response.
I will.
Yeah, I'm
Yeah,
trying to
People show up,
understand
You guys know
about
it's nothing.
You get smells and bells and people don't go.
You get a structure fire, people go, oh my god, I get to go out.
We had our car accident a couple weeks ago. We actually had like 3 people that showed up that I hadn't seen in
The one in
months.
Amesbury?
No, we had one. We had our own in
River
River.
Street.
Yeah. Arky has, I don't know, he's got access to those cameras right there on the corner. He showed me the video and it's just crazy. Cause like literally the car came around the corner and hit the other car. And then the guy gets out and literally no more than the guy's getting out. The sheriff comes around the corner off
Because
the
they were
bridge.
chasing them.
Yeah, and well, the state troopers were. So the
Yeah.
sheriff comes around the corner, then he starts running after him. Then you see the state trooper come running. Then you see the sheriff come back because he fell going up the hill.
Oh God.
So
Can I
he
just
came
have
back
that
to his
clip of video,
car.
please?
If I could get it, I probably would.
I would really love that.
You crackers?
You can't see him. You can't see him falling when he's going up the hill, but
How'd you know that, Roger?
it was the older sheriff that I think he worked at the school.
Oh, you know who that is.
I do.
And then cut on his nose and stuff like that.
It's,
That was a nice
He's a
one.
good guy.
it's been a different change of pace in our colony lately, so. But it always seems if I'm busy doing something, there's too much. We should go.
You get your training wheels tomorrow night.
I know, driver training.
I don't know what we're doing tomorrow. I think we're going to watch John Weatherby's parking lot because he has clients coming to possibly purchase the bank.
Yeah, we're driving rodeo, so.
We need to do a drive rodeo. That would be helpful.
Not that I'm ever, well, come on.
We got Dusty Bro.
We've got you and Frank that I'm gonna monopolize driving if you respond.
Not necessarily.
And Dylan, Obet, that's starting to drive. I said starting to, be nice. And, what's his face when he's in town?
Michael?
Nope,
Robert.
yep.
He's not in town.
Michael's in town. So,
I figured we'd talk about it, not like draw a graph and everything on there.
And he let him drive a couple times so far.
I can definitely see it.
Actually, he
I don't
drove
know
in
what I'm
Berkshire.
looking at, but I can see it.
Really?
Yeah.
I don't believe that was honestly.
well,
He's really smart, so he's actually really smart.
We just stole Joe from St. Albans. St. Albans Town Fair.
Joseph.
He would like to go picture.
Sorry.
Were you not there for that?
I wasn't out there for that.
Maybe you should show up to Joe more often.
Joe.
Oh, I don't know his last name. That's not my requirement.
That's Joe's.
Yeah, Lieutenant. You know your department.
I think everybody's back, so we could probably hit this and.
Do you have anything else you want to talk about?
Nope, no, you can talk about that first, because we're gonna jump into.
Okay. So this is something you guys should see in your book. I don't know if you really meant to say anything about this. This is definitely something you may see on your EMT exam. Understanding the different.
It also may come up later in like respiratory emergencies too, so
Right.
we're just gonna kind of talk about it a little bit here, because it does have an anatomy aspect to it.
So this is kind of my quick hand draw of what a respiratory cycle looks like. So understanding the different portions of this during normal breathing patterns, especially when you get into respiratory emergencies, to recognize abnormal breathing patterns. So just to give you a frame of reference, when you take in your max inhalation, as much air as you can take in, that's normally about 3 liters of air in volume, and vice versa. When you exhale, so you take a deep breath and then you exhale out as much as you can. So everything that we've inhaled for max inspiration is 3 liters, and then everything we exhaled is an additional 3 liters. So total lung capacity is 6 liters of air in volume. Okay? Now we're not breathing and exhaling as much as we can every time, right? So what we normally do during normal respiratory pattern is tidal volume. And this is a big thing that you're going to hear over and over again when we do respiratory emergencies. So tidal volume is the amount of air that moves in and out of our lungs during one respiratory cycle. So during one cycle of inspiration and expiration. So a normal average adult is 500 to 600 milliliters. Anybody have any idea how much air is held in our BVMs?
Something like 450 to 7 something.
Double
1 liter.
that.
Or I was gonna say it's about
1 liter of air is in that bag. And
Some of
in
them,
an adult bag.
some of them are higher than that. Some of them can go up to 1,500 mLs.
Right. So when we're breathing somebody, we're bagging somebody, do they need that whole bag of air?
No.
Half of it. So when we bag somebody, all we're looking for is chest rise. So our chest typically rises about 2 inches. Once we see that chest rise, we know, okay, that's enough air, and we let off our bag. So if you see somebody that's cranking down on the bag trying to breathe for somebody, you can actually cause barrel trauma, which is overinflation of the lungs, and you can cause a pneumo from that. So when
We'll
we're-
practice a lot of bagging later.
Yeah, definitely, to get you guys a feel of it.
So are you saying the tidal volume goes from neutral up, or,
So this is inhalation and exhalation,
okay,
and that's 500 to 600 milliliters,
from, okay,
top to bottom.
Yep.
That's how much air you take in and exhale during one cycle. Now, where respiration takes place, so where gas exchange takes place from our alveoli to our capillary bed, actually occurs during our functional residual volume, or our, it's kind of like our dead space. Our dead space actually sits in our trachea. There's no capillaries or anything sitting up there, but that's kind of the air left over in our lungs when we're not taking in a breath and when we're not exhaling. That's when gas exchange occurs. So our max residual volume, our max functional residual volume is 3 liters. Okay, so where you would be asked a question is, during what phase of the respiratory cycle does gas exchange occur? That's during our functional residual volume. Another question would be, what is the, what is it called for a normal respiratory cycle? That would be your tidal volume, okay? I wouldn't necessarily hone in too much on these values. This one I would know. Your normal tidal volume, which is 500 to 600 milliliters. The other thing you might be asked on is minute volume. So minute volume is your tidal volume times respiratory rate per minute. Okay? So take somebody who's got 500 to 600 milliliters per breath. Normal respiratory rate is 12 to 20. So you take 500 to 600, whatever they're breathing at, and multiply that by their respiratory rate. And that gets you minute volume. Okay? That comes more into when we do respiratory emergencies, especially if we're setting somebody up on a vent. Those are things that we need to know. But for your guys' sake, just understanding the different components of the respiratory cycle, especially tidal volume.
Just out of curiosity, is that 6 liters, that max capacity, is that both lungs?
Both lungs.
So it's 3 liters per lung?
3 liters. A little more on the right because your right lung actually has 3 lobes, whereas your left lung has 2 lobes.
Oh yeah, I totally forgot that in anatomy.
I know
Whoops.
they didn't mention it.
That is very surprising that they didn't mention that.
Yeah. So
Yeah.
your right lung has, if you were to cut somebody open and you looked at their right lung, there's actually 3 different lobes of the lung. They're all separated. You have your apex, your inferior portion, and then your medial portion. They don't even really show it in the picture.
No, they don't.
But understand that your right lung has 3 lobes, your left lung has 2 lobes. Okay? Why does it make sense for your left lung to have 2 lobes?
Because your heart is like,
Your heart sits on the left side. Exactly.
if you have one.
Right. Unless you're somebody who developed with a heart on the right.
So if you're like, I don't know if this really matters, but if you're like living with one lung, in theory, it's better to have your right lung.
In
Yes.
theory.
Yeah.
And if we're laying somebody on their side, if there's no injury or anything that would obstruct from laying them on their left side, we would lay them on their left to allow max expansion of the right lung.
That makes more sense now why you guys always send pregnant people on the left.
That and
That is-
pregnant females.
wouldn't that
Once we
potentially
get dog
cause
surgeons.
more stress on the heart?
No,
Because that would
not really,
be, no,
because your heart sits in what's called the pericardial sac, which acts as just a cushion around the heart, so that prevents anything from really pushing on your heart.
Okay.
That's the main thing. Now, if they have a pneumo or collapsed lung, blood pooling up, that kind of stuff, then that's going to change how we position them. Foreign patho. So I'll leave that up for a little bit.
Cool.
Good stuff.
Garrett's so smart. Alright, so let's get back into it. We got basically the cardiovascular system to hit up on. So, it's made up of 3 parts. Our heart, our blood, and the blood vessels. Pretty simple. Let's talk about the anatomy of the heart. So, heart has 4 chambers. We have 2 atria, or atrium, right and left atrium. We have 2 ventricles of the lower areas, so our left and right ventricle. The pathway through the blood, the pathway through the heart is right atrium to the right ventricle, out to the lungs, comes back to the heart to the left atrium, drops down into the left ventricle, and then goes out through the aorta to the body. And the whole cycle starts again. Okay. Here's a little pathway through. It's actually kind of numbered here. So we start in the right atrium. We drop down through our tricuspid valve into our right ventricle. At this point, the heart will pump. The right ventricle will send deoxygenated blood out to our lung through the pulmonary artery. Okay. I think we were talking about this before. So
There's your artery.
there's your artery. So what's the difference between arteries and veins?
Arteries are
Generally,
Squirt.
What's the difference between arteries and veins?
Arteries squirt, veins leak.
Arteries push blood away from the
arteries
heart.
pressurized
Yeah.
blood, usually oxygenated. Veins are,
That's where the misconception is.
Yes.
I said usually.
Usually, but
That's a classic NREMT
It's-
question.
yeah.
They're going to ask you, what is the difference between arteries and veins? And their options will be, one carries blood to and from the heart, one carries oxygenated, one carries deoxygenated.
that's where they're going to get you. Yep. So basically, in general, the easiest way, arteries carry blood away from the heart. Veins bring blood back to the heart. It's the easiest, simplest way to think about it. Don't think about it in terms of oxygenated versus deoxygenated. Because the pulmonary artery goes away from the heart, however, it carries deoxygenated blood. Takes it off to the lungs for reoxygenation. So, the easiest way, if you ever see that question on the NREMT, it's arteries flow away, veins come back. So, once our blood heads off to the lung, goes through all that area, gets reoxygenated, it's going to come on back, it's going to hit the left atrium. From the left atrium, it's going to drop down to our left ventricle through the mitral valve or bicuspid valve. From the left ventricle, it's going to get squeezed, and it's going to be shot right up through. It's kind of really weird to see, but it's right here. See, this is our aortic valve, so the blood's going to shoot out up through our aortic arch. From the aortic arch, you're going to see these 2 shoot up. Those two arteries, those are the carotid arteries. They're the ones that are going to shoot up to our neck and perfuse our brain. The rest is going to shoot back down into come down through the superior aorta here and come down and head off to the rest of the body. We're going to talk about the different arteries here in a moment. So our descending aorta is another important part. It runs basically from this lower half of our heart, runs right down our spinal column, the front side of the anterior side of our spinal column and spinal cord, and it goes right down the center of our body. So it comes down and basically gets to just below the belly button area, and it's going to split off into the iliac arteries. The iliac arteries are going to turn into the femoral arteries and head on down to the lower legs. The arms will come in through the axial artery and brachial arteries and come on down it, and will run down into the radial artery, down to the end, down into your hands. Any questions on kind of how blood flows through the heart?
There's a guy on YouTube called the Paramedic Coach. He has a great video on this. That's how I got that.
Yeah.
But on the tests, are we gonna need to know the valves, the tricuspid and bicuspid?
Yes.
Okay.
You will want to know the tricuspid, the bicuspid, and the aortic valves.
We will need to know those.
from a structural standpoint, which ventricle do you think is bigger, left or right?
Right.
Wrong.
Left.
Left.
Left is bigger.
Yeah,
Because
because
the
right,
blood's off.
right goes to the lung, left feeds the whole rest of the body.
Yes. Yeah. Your right doesn't have to pump very far. It's just going to your lungs. The left has to pump all the way around. So yeah, it is the stronger, thicker wall, and it's pretty well represented here in this picture. You can see the thickness of the wall on the left
right
side here
muscle.
compared to the right side. Another name, actually going back to kind of muscles and cardiac muscles, so another name you might see for heart muscle will be myocardium. That might be a term you might see. They might throw that term at you to describe cardiac muscle. It will be, what type of muscle is the myocardium? You might see something like that. Just be advised that it's just another name for the cardiac muscle. Alright, so let's talk about the conduction system.
This is Joe's and my bread and butter. That's what we like.
I made some notes so I would not forget a few things. Alright, so conduction system. We talked a little bit about automaticity at the beginning of the lecture when we kind of talked about the different types of muscle. So this is where automaticity comes into play. So you heard me talk about our pacemaker cell. There's one cell in the heart that starts all of this. He's going to be sitting right up here in what we call the sinoatrial node. He is the pacemaker. He is the king, the emperor, the sultan, whatever you want to call him. He is king shit of shit mountain. Yes, I'm putting it that way. He's the boss. When he decides to fire, he is going to fire at about a rate between 60 to 100 times a minute. What he's going to do is he's going to shoot a signal. They're going to come down what we call these internodal pathways. So there's 3 little pathways here. He's going to hit the atrioventricular node, AV node for short. The AV node is going to be like, hey, cool, signal. He's like, I'm going to hang on for a second before I send this. He's going to stop the signal for just a split second. Why do you think he's going to do that? Why do you think the AV node is going to hold that signal for a second? Think about the placement of where you're seeing these nodes. Think about where they are placement-wise. Why do you think he's holding on to the signal?
Because it allows the moment for the blood to move from the top part of the heart to the bottom part.
Bingo. So when the SA node, so sinoatrial, we typically abbreviate SA. So when that SA node fires, that's the signal for the atria to go. They contract. They start filling the ventricles up. So the AV node, he gets the signal. He's like, cool, I got the football. He's like, oh wait, I'm supposed to throw it on. And he throws it on down. So that split second just gives the ventricles time to fill up. So the AV node shoots the signal right on down the bundle of His. The atrioventricular bundle, or the bundle of His is another name for it. So it's these 2 pathways that kind of come down the center of the myocardium there. It's going to come down and they're going to loop right back around. These are what we call the bundle branches. These two pathways down the center here. They're going to hit the bundle branches, and they're going to come around to the Purkinje fibers. That's going to be the smaller sections as they start getting out, the smaller sections here. As it's going by, it's signifying the rest of the rest of the cells in there to contract. So this is when the ventricle is going to go and contract and pump blood back. Now, do you think the ventricles fire at the same exact time?
No.
Yeah, there's a slight delay. Typically, right fires before the left. Just a split. You can actually hear it when you all decide to go into medic school, which I know all of you will eventually. They'll teach you actually how to listen to the heart and what the different sounds, the lugged up and all the different sounds that the heart can make. They'll actually teach you how to pick up on all that stuff. It's actually a very difficult skill to master. I've not mastered it. But it's a pretty cool thing to hear. But yeah, so that's how the conduction system. So the SA node is going to fire a signal about 60 to 100 times a minute. So that's its intrinsic rate. That's where we get the normal heartbeat range of 60 to 100. That's our normal heartbeat range. As we get older sometimes, or when we get some sort of cardiovascular disease sometimes, the SA node tires out. Did you want to bring that up, or were you? Okay, oh, you're just writing them
That's
there.
what the pacemaker is, right?
So the pacemaker is the SA node. He is the pacemaker cell.
Right, but like when like patients that have the pacemaker, that's what it's doing.
We'll talk about that in a minute. Yes, basically. That's just an artificial one that's taking the place. But so once the SA node, if the SA node fails down, so let's say you get a disease and the SA node stops firing for some reason. It gets starved out, has no ability to fire anymore. The AV node's going to be sitting there, kind of sits there going, "Hey, you going to send me something?" Guess not. He goes, "Okay, well, if you're not going to do it, I'll do it." So the AV node fires. However, the AV node's not as strong and powerful as the AV node. He's like a little lord. He's like an earl of a kingdom somewhere. So he can only fire at 40 to 60 times a minute. So not quite as fast. If the AV node, if you're in total heart failure and you're down to your SA node and your AV node have completely died, not working, your Purkinje fibers take over. They're like the peons. They don't know what they're doing. They're like, "Whoa, I'll fire! No, I'll fire! No, I'll fire!" All hell's breaking loose in the heart at this point. They're so disorganized. The most that they can figure out is they can get the heart to pump 20 to 40 times a minute. That's about it. When you're getting down to this rate, things are going really bad in the heart. EKGs look really bad. Patients pretty well, they're on their way out. They've got some serious problems, some very bad problems that need some very serious fixing pretty quickly. So, yeah, that's my little description of the heart. That was actually a little bit more than I was going to do, but
No, that was good.
any questions on it? Know your intrinsic rates. Those will come up. 60 to 100, 40 to 60, and 20 to 40. Know those rates. Those will come up. They will be, you'll definitely want to know them when we get to cardiac emergencies. They will be important. Know the 3 different pacemakers. Know your SA node, your AV node, and your Purkinje fibers. Know the pathways. Know how the electrical signal is going to flow through the heart. You're going to want to know these things. These could be questions that come up on your exams.
And this is why we do 12-lead EKGs. This is what we're looking at. When you put those stickers on somebody, that's what we're looking at, is the electrical pathway in their heart. We can get a lot of information from that. One, how well their heart is functioning, if there are any dysrhythmias, or if they're having a heart attack. So, if somebody's having a heart attack, how would that affect their electrical pathways?
Well, they're not in a normal pattern or a normal sinus rhythm, so.
They can still be in a normal sinus rhythm. What's happening when we're having a heart attack?
Blood isn't getting pumped,
Blood's not making it to where it needs to,
damage.
so tissue's dying. If tissue's dying, our important muscles, our important cells are dying. What do you think that's going to do to the electrical pathway?
Try it.
It's not going to do anything, because now those cells are dead, they can't take a signal or send a signal. That's going to change our EKG.
What happens in those cases is what, so if you have cells along your Purkinje fibers, or even let's say around your bundle branches here, because these are common. You may have heard, maybe if those of you that have worked in the medical field, you may have heard left bundle branch blocks, right bundle branch blocks. You might have heard those terms before. Well, that's what we're dealing with here in the bundles. So if it dies, like Garrett said, cells can't receive a signal, can't send a signal. So what's the heart do? Well, it creates a detour for the electrical signal. That detour goes around the dead cells. However, what does a detour do? It takes more time, right? So that changes the way our EKG looks based on the timing of the electrical signal and how it hits. Now, will an EKG tell us how strong the heart's beating?
No, it just shows you the rhythm, right? Or
What's the EKG reading?
Well, it's electrical.
It's reading the electrical signal, so does that tell you how hard the heart's beating?
Well, yeah, wouldn't it? Because, no.
His one thing we check to tell us how
What do you
well
check?
the
What do you
heart's
check to see
pumping.
how well the heart's beating? Pulse. Yeah. So
Pulse.
you can have a normal sinus, regular looking EKG, and no heartbeat.
It's called PEA.
Yeah. You can have a normal conduction system, but no muscle to firing.
The heart's just quivering.
The heart's basically dead at that point.
That's why we always check a pulse.
Yeah.
You go to anybody unresponsive, you put the wires on them and do an EKG and it's showing a normal sinus, and you're wondering, why aren't they breathing? Because they don't have a pulse.
Yep.
Just because there's something on the monitor doesn't mean they have a pulse. Check the pulse.
Important to know that if when you get going and start working with medics and stuff, that will be something that will come up. We always check pulses. So, any questions on the conduction system? All right, cool.
It's the
So,
conduction system in
it's a
nutshell.
lot. Huh?
It's the conduction system in a nutshell.
Yes. There is so much more to it. We could probably do. We could probably talk for the next 2 weeks if we wanted to jump into like a full physiology lesson of how the heart pumps and everything. We could do a week or two alone on just this. So it's pretty cool. I threw these in the thing, but anyway. So I didn't realize you were gonna write them up there.
Yeah.
Coronary arteries. So let's talk about arteries for a minute. So coronary arteries. Coronary arteries are the lifeline of the heart, right? It's how the heart perfuses itself. We have our aorta, our pulmonary arteries, carotid and femoral arteries. We kind of talked about those, where they go. But let's talk about the coronary arteries. Very important role. When do you think the heart perfuses itself? Obviously, it's got to find a way to get blood to itself, right? When and how do you think it does? Well, we know how it does. It does it through the coronary arteries. But when does it do it? Pretty sure it made mention of this in the chapter.
He did.
Yeah.
You would think at some point while it has it, right? Like it just takes what it needs before it sends the rest out?
Nope.
Kind of thing? No.
Well, I mean, kind of. So the heart's going to perfuse its coronary arteries. So if we back up to, this picture I guess we'll do. Maybe this one will be a little better. It's zoomed in a little bit more. So when the left ventricle pumps, it sends blood out through the aortic arch, right? So it comes up through here and goes off to the body. So once the left ventricle relaxes, any blood that's left over in here, there's some small offshoots on the aorta on the backside that you can't really see in these pictures, that are just like small little valves there. Those go off to the coronary arteries. Kind of a little picture of them.
So it's pumping unoxygenated blood to it?
No, because it's coming from the left ventricle.
Feeds the right side of your left coronary artery.
So it's getting oxygenated blood, but it's getting it during its period of what we call diastole. Remember blood pressure. Systole is when it contracts. Diastole is when it's at rest. So the heart perfuses itself during that diastole moment, by the diastole. That's the moment that it perfuses itself. It's whatever's kind of still in the aorta kind of loops back down kind of into those coronary arteries. Remember, the coronary arteries are kind of tiny comparatively to other arteries that are in our bodies.
So there was no damage.
The coronary arteries are actually fairly small
Yes.
in diameter, very tiny.
Yeah.
So it's amazing what cardiologists are able to do when they snake those wires up into a heart and into the coronary arteries to open blockages up. They're not super big arteries. So these are kind of the main ones to know. You want to know, do they get tested on their coronary arteries? They made a big point to talk about them in the chapter. I do know that.
I think they just so you know the main left and right coronary.
So you want to know your right coronary artery. You want to know your left coronary artery, which breaks into your left marginal and then the very important left anterior descending. Those are kind of the big ones to know. The left anterior descending has a nickname. If it clots up at the top here, it's also known as the widowmaker. Typically people
Anybody's ever
don't
heard
make
of
it.
the widowmaker? That's the widowmaker.
Yeah, it's when if the clot is high in that, the left anterior descending perfuses about 75% of the heart. So if that goes, a lot of the heart goes with it. So typically people that have a massive heart attack in that vein, if it's high up, they very likely code with EMS in the field.
Right.
Very
There's cases
possible.
you hear about where somebody was perfectly fine talking to you, and then all of a sudden they just collapsed and died. Majority of the time it's due to that.
I had a guy, he got better. Gave him aspirin, gave him nitro, his elevation went away. The ST elevation and his EKG went away. Pain went away. We got him to the ER. We were there for 10 minutes maybe. He coded twice in the ER, once in the bay, and once on the way to UVM. Every single time we got him back with a shock. Not quite sure how. He ended up with a 99% occluded LAD. High in the LAD. He got lucky. Very lucky. But they happen. They're probably the ones that are gonna code on you the most sudden. So we talked about those. Let's talk about a few others. We talked about the brachial artery. We kind of talked about that a couple classes ago and kind of how to find it. We have a radial artery, which we find down on our wrist. Our posterior tibial artery. Which one's that one? You guys think you know that one?
Back of your ankle?
Yeah, it's back of your ankle. And then your dorsalis pedis artery is the top of the foot. And I found, we're going to just kind of skip ahead real quick and then we're going to come back.
Hi, my name is Zach, this is Harrison. Today we're talking about where to find the peripheral pulses in the lower limb. Now this is just a brief overview as to where to find the pulses. If you're after a full peripheral vascular exam, I'm afraid you'll have to look elsewhere. We'll assume for today that you've already washed your hands and consented the patient. There are 4 pulses to be aware of in the lower limb: the femoral, the popliteal, the posterior tibial, and the dorsalis pedis. We'll start with the femoral. The key to finding the femoral pulse is finding the mid-inguinal point. As I'm sure you'll remember from anatomy class, this is located halfway between the aces, the anterior superior iliac spine, and the pubic symphysis, which is in the midline. The femoral pulse can be found several centimeters below this mid-inguinal point. Pro tip: to avoid awkward encounters, get good at finding this on yourself before you start poking around in other people's groins. Next is the popliteal, which is found behind the knee. To measure it, bend the knee to about 90 degrees, like so. Place both thumbs on the tibial tuberosity and feel behind the knee with your fingers. Next, the posterior tibial. This is located posterior to the medial malleolus, halfway between it and the heel. It's best felt with the foot slightly inverted. Finally, the dorsalis pedis. This is located halfway up the dorsum of the foot, just lateral to the tendon of the extensor hallucis longus muscle. This tendon can be identified by asking the patient to lift up their big toe. Once you've finished with the peripheral pulses, you can move on to the rest of the exam.
So I found that by accident.
Hey guys, thanks for watching.
I found that one by accident, but I thought it would be a good one because finding your carotid, finding your radial, they're fairly easy arteries and pulses to find and become good at finding. The legs, on the other hand, those arteries can be tricky. Those pulses can be very tricky to find, especially the femoral. Some people are really good at finding it, other people not so great. I'm at finding that one. But like I said, practice on yourself or partner or somebody first before you go doing it to random strangers.
When do we check pedal pulses?
Broken leg, any
Lower
sort of
extremity.
trauma to the extremities.
Any lower extremity injury?
Yep.
Always checking the pedal pulse.
From experience, the dorsalis pedis is the easiest one to find.
And when you find it, mark it.
Yep.
Keep rechecking it. And when you check a pulse, what fingers do you use to check a pulse? Why not your thumb?
Because you have a pulse in your thumb.
You have a pulse in your thumb. You can interpret it as your own pulse.
2 to 3 is appropriate for finding. I usually use 3. Covers more surface area.
Always use your fingers, not your thumb.
So some of the other veins and arteries are in red, veins are in blue. Just some of the other ones that kind of go through our body that are not necessarily, know your superior and your inferior vena cava. Superior comes back from obviously the top of our body. This inferior vena cava brings blood back from the bottom, from our legs and abdomen. Know those. know the ones that we've already talked, radial, brachial, femoral. Know your carotids, your external jugulars. Your external jugulars, some people you can see them pretty, if they get mad, you can see them pop right out.
If you hold your breath, it'll pop out.
Yeah. They're great for IVs. They're big. Yeah, easy to get, but I've missed the last 3. Any other ones they should probably know commonly? I feel like those are probably the big ones that you might see questions on. But as you can see, there's a lot of them, and that doesn't even get into capillaries. So let's talk about the circulation. Speaking of capillaries, let's talk about circulation. So we talked a little bit about it, about blood through the heart. So when blood heads out from the heart, it travels down our arteries. But like with respiratory, we have our main bronchi that break off into bronchioles as it reaches smaller and smaller levels. Well, same thing happens with arteries. As you go down and the blood starts branching off the arteries, you get into arterioles. Those are like smaller arteries that continue to shrink as it gets down into the capillary beds. Once we hit the capillary beds, gas exchange happens. This is where the nutrients are exchanged, waste is taken from the cells and sent off to the necessary components. Like we said, either it's the lungs or the kidneys or the liver for cleaning, depending on the waste product. As it leaves the capillary bed, it's going to go reverse order. You're going to hit venules, small veins, tiny veins. Eventually that's going to go into bigger veins. Those bigger veins will end up back into your vena cava. The vena cava will dump the blood back into the heart for recycling. That's basically how your body takes the blood around. Are they up? Yep. Good. So, for homework, I'm actually going to give you guys a little bit of a homework assignment for Thursday night. If you're not going to be here, email it to us. Shit. Nice try. I know you guys aren't going to be here Thursday. So just email it to us. Email it to me or Garrett or Derek or all 3 of us. What I want you guys to do is I want you to take a molecule of oxygen. And I want you to trace it from when it enters the body till it exits the body. Kind of get what I mean?
Yeah.
So what I want you to do is I want you to do it however you want. Make a song, I don't care. Write a paragraph, write a little tiny essay, or just even list out the order. I want to know the order of the locations that passes through as much of the anatomy as you can name. So this will just help. This is actually something that was given to me when I went through EMT school. This is what my instructor did for us. If you can get this down and get as many of these things, as many of the structures memorized of how an oxygen molecule enters the body, goes through, ends up at the cells, and then the CO2 comes back out. If you can do that, that will help you understand the flow of oxygen and blood through the body. Cool?
Yeah.
Okay. So, any questions on the circulation of blood? Alright, cool. So let's talk about the composition of the blood, because this is kind of important to your homework assignment. So, plasma, which is basically the salty fluid mixture of blood, makes up more than half of the volume. Red blood cells, which are made up of our red blood cells, our erythrocytes, and our red corpuscles. These are just different types of red blood cells. These are our oxygen-carrying buddies. So everyone knows red blood cells have hemoglobin on them, right? So hemoglobin is what attaches, which goes, hey, oxygen, give me your hand, and they hold on tight and take it to the cells. That's the job of the hemoglobin. When CO2 comes back, so when CO2 gets dumped from the cells, nothing attaches to CO2 and carries it back. CO2 actually just kind of dissolves itself into the plasma and just rides the waves back to the lungs. Doesn't really attach to the hemoglobin, doesn't catch a ride with anyone, just freeloads itself back through the plasma. Then we have our white blood cells. Our white blood cells fight infection. We have leukocytes, white corpuscles. There's actually 5 different types of white blood cells out there. We don't really need to go into all of them. Just know that the job of white blood cells is to fight infections, fight off foreign bodies that may enter the thing, and to create antibodies for viruses, bacteria, and the such. Our platelets are our clotting factor. These are what these guys circulate throughout the body and go, ooh, a hole in the vein. Stop. They stick together. So platelets are very sticky. So when one of them finds a clot or finds a hole and goes, nope, I'm sticking here. I'm hanging out here. Every other platelet that goes by and goes, oh, hey, cool. I'm stuck to you now. And they basically just congregate until they create that clot. You'll notice that's basically what happens when you scab over. It's basically dried out platelets that have clotted that area. They scab over, and you get your skin that grows underneath it. So these 4 things make up our blood. It's important to know. So now what we're going to do is we're going to talk about pulse. We talked about it a little bit before. It's the pressure wave of blood flowing down the artery when our left ventricle contracts. And obviously we feel it. We feel it actually by compressing the artery against the nearest bone that's there. That's how we feel it. We've talked about these, kind of beat them to death, I feel like, late today. But we have our outer parts of our body, which are called peripheral pulses. So that's our radial, our brachial, posterior tibial, and the dorsalis pedis. The central core pulses are our femoral and our carotid. So this tells us how our core cardiovascular system is doing. That's why it takes less blood pressure to function these pulses than these pulses. You watched that already. Why are you doing this to me? Boy. Okay. Sorry. So blood pressure we talked about when we talked about vital signs. So it's the force of the blood exerts against the blood vessel walls. Our systolic, which is our upper reading, this is when the left ventricle contracts. This is the highest pressure that is created. This is why it's the top number, it's the highest number. You can't have a higher diastolic than a systolic. It's impossible. Your diastolic is your lower reading, so this is when the left ventricle is filling. So when it refills, when it's at rest, when there's no exertional pressure put on the walls, this is what your diastolic reading is. Let's talk about perfusion. This is a term you're going to want to know. Perfusion. Perfusion is adequate supply of oxygen and nutrients to the cells of the body with the removal of waste products. Okay? So this is what you're going to want to know. You want to know this definition. Hypoperfusion, which is what shock is. There's many types of different shocks, and we'll talk about the different types of shock when we get to that area. When we get to that area of teaching or class. This is when perfusion becomes inadequate. Name a few things that could cause some inadequate perfusion. Common things right off the top of your head that you can think of that would cause inadequate perfusion.
Loss of blood volume.
Loss of blood volume. Yep.
Cardiac arrest.
Cardiac arrest. Yep.
Hypoxia.
Hypoxia. Yep.
Respiratory distress, cardiac distress.
Tachycardia.
Yep.
Hypothermia.
Hypothermia. Yep. Yeah.
Traumas.
Pretty much anything we deal with has the possibility of causing hypoperfusion. And it can be something as simple as not enough nutrients, not enough oxygen. It could be one of those things. If one of those things becomes imbalanced, we end up in a shock or a hyperperfusive state. We don't want that. We want normal. We want to be in normal perfusion. We want our body to bring us the stuff we need and get rid of the stuff we don't. Alright. How is the function of the respiratory system related to the function of the circulatory system?
You're not breathing, you're not pumping.
Well, they have to work in tandem.
Yeah.
Yes. Work in tandem. If one's not working correctly, the other one's soon to follow. Yeah, they're and that's why a lot of times you won't see cardiovascular and pulmonary. A lot of times you might see it combined as the cardiopulmonary system. Because they work with one without the other, you don't have life. They have to work in tandem, they have to work together in order to keep us in homeostasis, to keep us in normal. They have to work together. Without the other, we die. And if one quits, the other one's not going to be very far behind. If the heart's not giving the lungs the stuff it needs to breathe, then breathing will stop. If the breathing stops, then oxygen doesn't get delivered to the heart, and the heart eventually stops. So they work so close together that they really are one system. Think about that, and that would be good advice when we start talking about cardiac emergencies and respiratory emergencies, because they're so closely together. Problems with one can result with problems with the other. So start thinking about them as just one system. When you're talking about cardiac systems, think about the pulmonary system also, because they are so close together.
That's why a heart attack can kind of be difficulty breathing.
Correct. Yep. So close. The heart's not pumping properly, so the body's not exchanging gases the appropriate way.
Yeah.
And vice versa. You can be having trouble breathing and not having chest pain, but having cardiac problems because you're not getting enough oxygen to the heart. So you might not be having a heart attack, but there might be signs that we might see on an EKG that would show that, oh yeah, the heart's oxygen starved because the breathing's not working right. We fix the breathing, we fix the heart. So we have a bit of a life support change here. Interaction of the respiratory system, kind of here where I was just talking about, kind of becomes known as one system, the cardiopulmonary system. Perfusion, again, it's general. We get the oxygen into where it needs to be, we get the nutrients into where it needs to be, carbon dioxide and other waste products are taken out for removal. So, any questions on cardiovascular? No? None? I mean, you guys are also more than welcome. If questions come up after lecture and whatnot, if you guys have other questions, feel free to email us. I want to say there might be like some sort of like forum question location on the MyBrady. So we'll see, maybe we can figure that out. So if you guys have more questions that come up like after class, we can kind of start forum discussions with certain things on there. So, with that being said, you guys are lucky and get to get out early tonight. Me and Garrett talked, we did decide to stop at the cardiovascular system here. It's a lot to take in. Next week you start on with like lymphatic system, you got the nervous system, you've got digestive. So next week will probably be a full 3-hour class. But we wanted to do these 3 big ones first to kind of get you guys thinking about it. There's a lot of information in these 3 systems, so we didn't want to overload you tonight with this stuff. So we're going to stop here for tonight. I am a little behind on the videos. It was a long weekend. I didn't get to them for the editing. I will do my best to try to get this stuff up by Wednesday. And obviously Thursday's class, I will try to get up over the weekend so you guys can view it for those of you that are leaving us for vacation or whatever it is.
Not that often, it's a family wedding.
Well, it's out of state, so it's kind of vacation one. It's kind of
Is
vacation.
it?
I mean, I guess everybody.
Family, so it's not a vacation for her.
So, any questions about anything tonight or upcoming? Cool. Guys, have a good night. Stay out of trouble.